This is Neurology Recall, a collection of our most useful, practical, and educational podcasts on a wide variety of topics selected from our neurology podcast collection. Whether you are new to neurology in training or have been practicing for many years, Neurology Recall is designed to help you continue to learn the essentials of neurology, easily, one podcast at a time.
Hi everyone, it's Jeff Ratliff, Deputy Editor of the podcast with the Neurology Recall for July 2023. Spanning across the subspecialties of neurology, we have featured a number of interviews on how not just biological risk factors, but socially determined factors can modify and affect disease risk and severity in neurologic diseases. We've brought together a number of these interviews today to highlight the social determinants of health across multiple fields of neurology. The first interview you'll hear is from the March 27, 2023 episode of the podcast, in which Stacey Clardy spoke with Heather Leeper on the links between pain and depression with unemployment in patients with central nervous system malignancies. Following that interview, we'll jump over to the field of epilepsy and feature a conversation that Hallie Alexander had with Wyatt Bensken about differences in antiseizure medication prescribing among people with epilepsy from different racial and ethnic backgrounds. That interview aired on the February 13, 2023 episode of the podcast. After this, we'll jump back to an interview from June 9, 2022, in which BJ Hicks and Andy Sutherland spoke with Scott Mendelson about racial and ethnic disparities when it comes to treating acute stroke patients with thrombolytic therapies. In the final two episodes, we'll discuss movement disorders topics. From the April 13, 2023 episode of the podcast, you'll hear my conversation with Vikas Kotagal about how neighborhood socioeconomic factors may vary across individuals with different types of movement disorders. And in the final interview, you'll hear Jason Crowell speak with Daniel DeLuca about racial and ethnic differences in health-related quality of life measures among patients with Parkinson's. That episode aired on June 19, 2023. While these interviews touch on only a handful of our neurologic subspecialties, hopefully they highlight the impact that social determinants of health can have on our patients across our clinical practices and help us better anticipate and respond to the unique challenges some of our patients may face. Thanks for listening to this month's Neurology Recall. We'll see you next month.
This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Stacey Clardy, and today I'm speaking with Heather Leeper. Heather is a neuro-oncologist and neuropalliative care physician, now on faculty at the University of Chicago. Until recently, and just before the move to Chicago, Heather, you were at the National Cancer Institute's neuro-oncology branch at the NIH, where you completed much of the work on this particular paper that we'll discuss today. The title is Association of Employment Status with Symptom Burden and Health-Related Quality of Life in People Living with Primary CNS Tumors. Heather, thanks for joining us today.
It's a pleasure to be here.
Your work and this paper in particular cuts right to the core of what matters to neurology patients. You are really looking at what it means to live and move forward with a serious neurologic diagnosis. In this case, primary central nervous system tumors, but this applies to a lot of our neurology patients. And you're addressing the hard questions. Am I able to continue to work? And if I cannot, what resources are available that might help me get back to work? And of course, buried in all of that is, can I even afford to ask the question of coming to work or not? Because in the US, of course, in many cases, our ability to access care, our health insurance is tied to employment. And further, having neurologic illness is expensive. There is a risk of tremendous financial toxicity from a diagnosis like a CNS malignancy. So these are all issues near and dear to us at the podcast. And of course, our late podcast founder, Ted Burns, devoted much work to raising awareness of these issues, both before and even more so after his own cancer diagnosis. So with that background, let's dig into the findings you made in this paper. I want to start with the answer to the question you asked, really. Why are some people living with CNS cancer able to return to work while others are not able to return to work? And what might be different between these two groups so that we can better understand their needs and the issues that they're facing and help them through it?
This is a really important question for all of the people who are living with the disease. And I wanted to understand better what's happening in the lives of these individuals and how can we help them? Is this a matter of needing medications or rather serious illness conversations and better understanding of what the symptoms are, what their physical impairments are, and what resources do we have within the US healthcare system to get them the help that they need so they can maybe do better. Maybe they can go back to work if they had more support, if they had more resources.
So you looked at a lot of demographics and a lot of variables, including several patient-reported outcome measures. What did you find?
We found that of the cohort available to us for this cross-sectional analysis, that 28% were unemployed specifically due to their tumor. And within the sample, Hispanics were 2.3 times more likely to report being unemployed. So it turns out that those participants within this cross-sectional analysis who were unemployed were significantly more likely to have impairment with their walking, with being able to do basic things like wash themselves, dress themselves, and perform usual activities. I know this is also known as performance status, and that there was a marked difference between the two. And corresponding to that marked difference, as you might imagine, health-related quality of life was significantly lower in those participants who were unemployed.
So that's helpful and answers really one of my other questions that was coming to mind. For many of your unemployed patients, the reason they weren't working out of the gate was because perhaps the tumor was severe enough and working was simply not an option. Is that right?
Yes, for some people, it was a mobility issue that they lost function in their extremities or a extremity, or it was cognitive impairment, or it was a physical limitation by a symptom because they were so profoundly nauseated, they had so much pain, or they really just could not sleep, and so therefore they couldn't function. And so, these patients probably had a lot going on. And using patient-reported outcomes to tell us what their lives were like, we were able to assess these different factors, which are explained in great detail within the paper. But I would be glad to summarize them and essentially say that patients who had hemiparesis and a lot of pain and a lot of anxiety and depression were the ones who weren't returning to work.
And it probably goes beyond the scope of this paper, but that's an important point you made there, right? If you can't go to work, maybe we need to focus our visit and symptom management with these patients even more so on mood. Is that a fair statement?
Yeah, I think it's important to ask patients what's really going on for you at home. Like, what's your priority? And what is it that you think that you need to be able to do better? What's hampering your quality of life? And what symptom is it that you need relieved the most so that you can, as a physician, can brainstorm, what is it that I have to take care of this patient better? Is it an antidepressant and a referral to psychiatry? Do they need psychological counseling? Do they need more aggressive pain management?
As you alluded to, there is quite a detailed breakdown of just a ton of variables in the paper. But let me ask, is there a difference that you found between brain tumor patients compared to spinal cord cancer patients?
We strive to include brain and spinal cord patients because so many rare cancer patients like ependymoma, where it only involves the spine, they often don't have any stats in this regard that are available to them. And in fact, it shows that the patients who had brain and spinal cord involvement were the most affected by symptoms and had the most functional impairment, as well as the higher symptom burdens. So I think this goes back to the fact that patients might need physical therapy, occupational therapy, more than just once at diagnosis, that they probably could benefit from reassessments by rehab medicine to get them devices, but also to kind of do tune-ups, if you will, if you want to think of it that way, with their physical functioning, that they might degenerate with their muscle and their spasticity function over time, and they might benefit from re-engagement with those services.
So with all of this data and the analysis and what you've learned from it, how do you counsel your patients now? And has it changed based on what you found with understanding in greater detail the impact of these diagnoses on quality of life?
I think that this reaffirmed my suspicion that patients aren't going back to work sometimes because they have profound neurologic impairment. That's not going to change. But some patients might have symptoms that are amenable to being better managed and have physical impairment that could be adapted to circumstances. And there is the potential for them to go back to work if they just had maybe more support. And I learned through this paper that there are return to work programs, and that within the United States, a lot of Americans live with disability, and their ability to go back to work is often impaired by the environment. And I think this is applicable to patients who have severe neurologic impairment. And often this is, more likely to be spinal cord patients in a lot of cases as well. So I'm thinking about patients living with inflammatory disorders like multiple sclerosis and things. I think that we need to do a better job about also counseling them about where they can get financial counseling. A lot of healthcare systems have some sort of navigator, social worker, financial counseling office where people can turn to for education about how their insurance works, how their pharmacy benefits work, when they might be able to be considered for charity care, be on bill assistance pay programs, maybe have some of their debt forgiven. And I think we just need to avail ourselves to the information within our healthcare system. Not that we have to own it, but rather at least know where we can send patients to get that type of help.
Yeah, I love hearing you mention this whole wide variety of things, because it's telling me that you're asking the questions, right? And so often we have to really focus to sit down and ask the questions of what are you struggling with? What do you need in your day-to-day? Tell me about the return to work programs. I don't think I know enough about that.
I didn't really either until I was looking for references for this paper and seeing other authors referencing them. But apparently they are multidisciplinary, because they've discovered if you send someone just to physical therapy, that in and of itself does not help the person return to work, but rather it's an interdisciplinary program. And in the paper, I discovered that the references were also for involvement with brain tumor patients. So it's not unique to just cancer, but essentially there are programs that are staffed by providers, clinicians in different aspects that help address patients' needs, because as this paper spells out, people don't have just one need, they have a variety of needs. And I think that's why these multidisciplinary programs are much more successful.
Do you bring these conversations up at the first visit or every visit? How do you work this in?
Well, I think wearing my palliative care hat whenever I talk to patients, it's helpful for me to ask them, what do you understand about your illness and what's happening with you at home? Where do you feel like you need the most help? And I kind of let them tell me where their needs are at that time. It might change from visit to visit, but I think patients are pretty good at having priorities for themselves. And I think I try to engage them in person-centered conversations as much as I can, and step away from, are you taking, your drugs as prescribed and things like that, but and really talking to them about how are things going for you and where do you think that you need the most help.
When it becomes apparent to you that the patient in front of you probably will not be able to return to work, how do you approach that conversation? And do you warn them about higher rates of depression and things that may come with that?
That's unfortunately a conversation I've had to have a lot. Some people temporarily don't go back to work, and they are able to go back later, like once they get through radiation. But a lot of people walk into my office thinking that their life is going to continue on as it was, but it's not. And so I'm frank, I don't hide the truth from them, but at the same time, I explain, you're going to find that going to work is very difficult because you're not going to feel well. And also you're going to find that doing your job is very difficult. And sometimes it depends on the job. Sometimes people have a job where they are able to not have to perform at ridiculously high levels and they can coast for a while. But often in this day and age, so many people have jobs that are computer-based. And if people can't type, they can't read, they can't follow, they can't pay attention, they're not able to do their job. And so I think sometimes even if I counsel them that they won't be able to do it, they find out for themselves that they can't do it. And I just let them know that if you find that you can't, that's okay. We'll figure out how to get you FMLA paperwork signed and get you through it. For patients who have a diagnosis of glioblastoma, where it's likely that they're not going to live all that long, we do have conversations in the field with our patients, letting them know that you're going to need to get your financial ducks in a row and consider applying for disability and things like that, because your finances are going to be drastically different than they were because of all of this.
And how do you intermix all of that with maintaining hope?
We talk about how we join them in their hope that things are going to be okay, that they're going to live as long as they can. And we also say that it's important for you to know that the most likely scenario is this, but I will be here with you the whole way to take care of you and to guide you through whatever comes. And really, that's what they want. They want to know that we're going to be with them no matter what happens.
That's really the essence of providing care, isn't it? Anything else that we should know from your work, what you've learned, how it's changed your practice?
I think we all came into this profession wanting to help people. And I think this is a great example of how we can make a difference if we have communication skills that are enabling us to get to the heart of what the person is experiencing and not focus so much on treating a disease, but treating a person. And I'd like to hope that things like this, using patient-reported outcomes to understand what's happening to our patients and listening to them better, could do them a world of good.
Yeah, it seems like it shouldn't have to be said, right? But in the systems currently, we really have to be intentional about maintaining that focus, right? And blocking everything else out.
It's become a muscle that we have to exercise ourselves, that we have to remember that we're not just taking care of a disease and focused on our drugs, that rather we have a person in front of us and they want us to take care of them, just like how we envision ourselves if we were sick, how we would want to be taken care of.
Yeah, that's an easy way to remember, isn't it? It's just put yourself in their seat. Well, thank you, Heather, for your continued work in cancer survivorship and neuropalliative care and your emphasis on the patient experience and on this intentional patient-centered framing. It's really the only right way to approach care in all serious neurologic disease, and such an important reminder to continue to stay focused on that. It's been wonderful to chat today. Again, the name of Heather's paper is Association of Employment Status with Symptom Burden and Health-Related Quality of Life in People Living with Primary CNS Tumors. Heather, thanks for joining us today.
Thank you for having me.
Hello, this is Hallie Alexander from Wake Forest University, and I'm here with Wyatt Bensken from Case Western Reserve University. Wyatt has an interesting background in epidemiology and health disparities research, and he recently published a paper in Neurology where he and his colleagues used Medicaid claims data to evaluate racial and ethnic differences in anti-seizure medication prescribing in people with epilepsy. Wyatt, it's a pleasure to have you on the podcast today.
Thank you so much. It's a pleasure to be here.
So can we start by you summarize your main findings from the paper?
So in our study, we used Medicaid claims data, and we had just over 78,000 individuals spread across 15 different states that were included in these data. And so what we did was we identified a whole host of covariates, including comorbidities, state of residence, and then also looked at the generation of anti-seizure medication that individuals were on, as well as their adherence. And so these Medicaid claims data are certainly a crude measure of clinical care delivery, but nonetheless, that sample size, again, of just over 78,000 really helps paint a population health level picture of these trends in anti-seizure medication use.
Right. And we all know that the newer generation of anti-seizure medications have less side effects. In a lot of people may be better tolerated and lead to better adherence. And so that's why it's important to pay attention to what generation of anti-seizure medications are being prescribed for which populations. And what do you think some of the drivers were for these inequities? You said that a lot of the non-white populations were less likely to be on the newer generation anti-seizure medications. So what do you think is contributing to that?
One limitation of these data is we didn't have the ability to understand the mechanism of these differences, but reviewing the literature and thinking as a team critically about this, there's a lot of drivers of this, whether it be a provider, a health system, or a patient level. And so everything from affordability of medications to trust between a patient and their provider, there's ample literature out there that highlights racial and ethnic concordance between providers often will improve outcomes. So whether that be a provider not understanding the circumstances of a patient's life, or a patient not feeling comfortable disclosing side effects, or poor seizure control. Ultimately, though, we think it's a real combination of all of these factors and the nature and privilege and power of the healthcare system versus these minoritized communities that contributes to the differences that we observed.
And now you used Medicaid claims data, so that means that insurance coverage was not a factor in these prescribing practices. But was there any way that you took into account the type of epilepsy that the patient had and the specific anti-seizure medications that were used in order to account for some of these analyses? For example, I'm thinking, maybe if the patient had a generalized epilepsy, it's possible that some of the older generations, such as valproate, could have been the preferred choice. So did you look at any of those extra factors?
Unfortunately, we weren't able to. Claims data are kind of notoriously bad in identifying really specific subtypes of seizures and epilepsy. And so that's certainly, I think, a next step is understanding why these patterns emerged. And I do want to highlight that we had just under 80,000 folks in the data that we used. So these were population level patterns. And so understanding, again, some of those drivers of epilepsy type, seizure frequency, things that claims data aren't always powerful to capture, I think is a wonderful next step for this line of research.
And what about next steps, not necessarily in terms of the research itself, but what do we do in terms of action? So what are next steps to help actually reduce racial and ethnic disparities in epilepsy?
I think sometimes it's hard when we do these kind of large claims-based studies to think about what that means for the practicing neurologist or epileptologist. And there's a few things that emerged from this that I want to highlight. I think the first is that we did see that folks who saw a neurologist were on newer medications more frequently than folks who didn't see a neurologist. So thinking of ways that we could expand access to high-quality neurologic care. Advances such as telehealth and telemedicine, I think, have done a great job, but continuing to identify where those gaps in access to care exist at the structural level are important. At the health system level, I think that what we did in this paper, the analyses, provides a framework to undertake a health equity quality improvement initiative to look at, within a practice, within a neurology practice, what patients are being prescribed, what anti-seizure medications, are there gaps that exist, looking at things like insurance coverage, primary payer that we weren't able to do. And then I think at the provider level, just thinking about your own practice with patients and how these aspects of racial concordance and trust come into play. The reality is in the United States, racism is unavoidable and permeates all aspects of our life and certainly the healthcare system. So just awareness of these differences and taking a pause and kind of evaluating both the structural healthcare system and provider level factors is at least a big undertaking, but a decent next step.
Yeah, a lot of work needs to be done here, but I'm glad you brought up both the systems level changes that we can start looking into, and then also on an individual level, things that we can do. So what is one thing you would say that we could take with us into the clinic today to help us check our own prescribing practices and make sure that as an individual that we're doing everything we can to try to address these inequities?
The biggest takeaway I would say for that practice level is being aware that these individual level interactions and patient care bubble up to these population level differences that we observe. And so recognizing that even a positive clinical encounter has the hue of racial concordance. Only just under 3% of the neurology workforce is Black or African American compared to 20% of our sample and about 14%, I believe, of the United States. And so thinking about how those factors come into that closed door office visit, they're unavoidable. And so recognizing them and addressing them with patients and among colleagues, I think, is a really important immediate step.
Yeah, there was a good example in the paper where you mentioned that African Americans may have more mistrust of the medical community, and so they may be less likely to bring up side effects to their doctor. And so it can lead to this whole cycle. So that's one thing, that I did take note of in the paper is maybe just being a little bit more explicit about asking clearly about side effects for all people and not just saying, oh, are you having any side effects from your medication, but asking this can look like, XYZ? Are you experiencing any of this? If so, we can work with you to find a different medication with the goal of being seizure-free and side effect-free. So thank you for those points.
Absolutely. It really touches on an important issue, which is that the power that the healthcare system has is massive. And unfortunately, the healthcare system, as we know it today, has a long history of really atrocious acts towards minoritized communities. And so that's the system that we operate in. And I think it's important to recognize that our paper wasn't trying to place the blame on individual providers, but rather recognizing that the healthcare system is a powerful structure and has taken power away from these individuals over time. And so exactly like you just said, right, is recognizing that that's the system we operate in and taking a pause and being more specific about the questions that are asked, or thinking about those social drivers of health that might play into both access to medications and then subsequent adherence, I think are really important steps.
Thank you so much. Again, I've been speaking with Dr. Wyatt Bensken about his recent publication in Neurology, which is titled Racial and Ethnic Differences in Anti-Seizure Medications Among People with Epilepsy on Medicaid, A Case of Inequities. You can find the full article in the February 7th issue of Neurology or online at neurology.org. Wyatt, thanks again for joining us on the podcast today.
Thank you so much for having me.
Hello, this is Andy Sutherland from the University of Virginia, and I'm joined today by my friend and colleague, BJ Hicks, who is a vascular neurologist and co-director of the Comprehensive Stroke Center at Ohio Health Riverside Methodist Hospital. For this week's podcast, Dr. Hicks and I had the pleasure of speaking with Scott Mendelson from the Department of Neurology at the University of Chicago. We're going to be discussing an article recently published in Neurology titled Race, Ethnic Disparities and Rates of Declination of Thrombolysis for Stroke. In this study, Dr. Mendelson and colleagues reviewed data from the American Heart Association's Get With the Guidelines nationwide stroke registry to determine the prevalence of TPA treatment declination, which for the purpose of the podcast, these are our eligible stroke patients who ultimately decline treatment with thrombolysis. And importantly, in this analysis, explore some of the differences in TPA declination by race, ethnicity, and other variables. So first of all, Scott, thanks for joining us today.
Thank you, Andy. Thank you, BJ. I appreciate the opportunity.
So just sort of get us started here in the conversation, I think it's fair to say that we know that this has been an issue, these disparities in TPA treatment rates, but also TPA declination in prior observational studies. And there are concerning race ethnic disparities in the use and access to acute stroke thrombolysis that many of us in the field are aware of, notably among Black and African American patients who are less likely to receive IV TPA. So Scott, just for our listeners, what are the new findings from this most recent analysis that you and your co-authors feel like add to this current understanding?
Sure. Yeah. Based on those observations you described, we first sought to determine the prevalence of declining TPA for acute ischemic stroke in a national cohort of otherwise eligible stroke patients. And then we investigated the difference in declining TPA for acute ischemic stroke by demographic variables, so including race and ethnicity. And so using over 3 years of patient data from the Get With the Guidelines stroke registry, we found that the rate at which otherwise eligible patients for TPA or their proxies declined treatment was fairly low at 3.7% in our study. And though this absolute rate of declining therapy was low, we found that when adjusted for factors like stroke severity or non-Hispanic Black patients, that those patients were 21% more likely to decline therapies than, say, non-Hispanic white patients. And so from this past research, we knew that Black patients are less likely than white patients to receive TPA when eligible. And our findings in this paper suggest that this disparity in part may be related to difference in declining medical therapies for acute ischemic stroke when offered.
Well, I would, again, like to send my kudos, Scott, for this very impactful topic that we're discussing today. I've got a two-part question, so bear with me here. What do you think we could take away from the stroke treatment disparities, specifically in regards to TPA declination, compared to other metrics such as mode of transport, hospital arrive times, and other TPA exclusions? And specifically, you and your co-authors highlight structural racism and provider, along with health system biases that likely to play a role. I would love to hear you further elaborate on these things.
Right. And I think that's sort of the crux of the issue. So One is, I would say, is that we need to continue to build and improve systems of stroke care, right? So that patients can benefit from fast arrival times, rapid evaluations, rapid treatments. That has to happen for sure. Now, among the sort of race and ethnic disparities that we discovered, we also found that patients arriving via EMS were less likely to decline care, while the opposite was true for patients arriving off hours. Again, sort of arguing that there are larger systems of care that need to be worked out in hopes of reducing disparities in treatment. We know that from other studies that off-hour arrival time has been associated with longer door-to-needle times. So the suggestion there may be that addressing these existing known opportunities of improved care, such as 911 utilization, again, improving off-hour hospital resources, all these could also impact the rates at which patients decline eligible therapies. The larger implication to your question, we think, though, is that data suggests that there may be an opportunity to reduce disparities in total in care at the level of the interaction between those healthcare providers and the patients or their proxies who are involved in these conversations around acute stroke treatments. Past research has suggested that most providers actually of acute stroke care prefer to engage in some informed consent process with patients. Now, this is either a verbal consent process or a written conformed process, but some exchange between patients or their proxies before treating with thrombolysis for acute ischemic stroke. Unfortunately, our data do not provide the detail needed to determine if that patient and provider level factors are driving this observed difference in refusing TPA therapies. I will say, since the primary audience of our paper is the providers of acute stroke care, we have an opportunity now to examine our practice patterns around informed consent for TPA and how we discuss this treatment options to patients, and whether that conversation may differ between who the audience is or who we're having these conversations with. So how information is received by Black patients or their families may be different, and providers of acute stroke care should be prepared to recognize these differences, and hopefully we can address them accordingly.
Scott, I just want to piggyback on BJ's question. Given the fact that we're continually confronted with these disparities, and then data like this highlights the impact of structural racism, provider system level biases, whether or not this could help fuel better training for our vascular neurology fellows, our provider workforce, and cultural competency, implicit bias training, better variations in the script of that consent process that you talk about, because obviously this continues to be a major issue and the data bears it out.
Yeah, I think that one product of this, or one suggestion from these data and this work, can be that we need to do better to train our physicians in talking about acute stroke therapies. There's both the education side on the pre-hospital side, so making sure that patients in the community know about what their treatment options are and the importance of fast treatment times, or at least fast activation of 911 and getting to the hospital. But built into that need to talk about what the next steps are and how time sensitive these treatments are, how helpful these treatments are, how beneficial they are to patients. So that's at the community and the patient facing side of things. And then maybe we need to drill down in how we train both emergency medicine physicians and neurologists and stroke neurologists about their acute therapies, about how we talk about risks and benefits of therapies with patients, and particularly in the setting of the emergency department, and particularly in the setting of acute stroke, where we aren't offered some of the luxuries, say, of time or of volumes of information that can be provided in the moment in order to obtain fully informed consent for these therapies. We may have to rethink our approach to the process. Some people have described a process of informed refusal, and that the motivation should be to administer these therapies and acknowledge that patients or their families have a right to refuse, but these are standard of care and should be administered when indicated and when patients are eligible. Or some people have described a situation where informed consent process may not be necessary because this is the standard of care, because the benefits for the practice or for the treatment outweigh the benefits. I think there's a lot of discussion in this arena about what the best fit for what scenario, and it might be different for lower volume centers versus higher volume centers that are driven by, say, house staff or have other models of acute care. It may differ, but we should come to some sort of understanding about what the core elements are necessary to have an informed consent process for these therapies. And the hopes, again, of sort of reducing some of these refusals, and as we suggest, maybe that would in part get at some of the disparities in declining TPA care.
Thanks, Scott, for expounding on that. I think that brings up a lot of important topics, as it relates to how we can do better in communicating with our patients about acute stroke treatment. Were there any other findings from the analysis? Obviously, this was the key finding, but were there any other findings from the analysis that you or your colleagues found surprising or noteworthy?
Yes, we found that besides race ethnic differences, we also found that women were actually more likely than men to decline TPA therapy. Our data, again, do not give us direct insight as to what may be driving this difference, but at the level of the patient, at least, this may come down to differences in risk tolerances between genders, or as with the disparity observed at the level of race and ethnicity here. With gender, there's a possibility we are noticing the impact of provider bias as well. So again, getting back to untangling what is the interactions between the patients and the providers, or the providers and the proxies that may be driving these disparities.
Scott, you've really given us a lot of great things to consider as far as future management of all types of patients that we see in the emergency room or in the acute stroke setting. What are any other next steps that you can envision regarding reducing these inequities moving forward? I know you've given us some, but is there anything from this data that has further interested you as far as something that we could arm ourselves with education, not only at the resident and fellow level, but also with established clinicians who might be practicing for years and might be using antiquated models for consent?
Yeah, thanks for that question, BJ. So, based on our findings, if we want to reduce disparities in acute stroke care, which I think we should, then we need to learn what patient and provider level factors drive decision-making in acute ischemic stroke therapies. So either through patient education, provider training, the goal of improving patient-provider interactions should be towards reducing this rate at which patients or their proxies decline care. And so whether that's education and training, or rethinking the entire model of around informed consent for acute stroke therapies, I'm not sure. But I think if we can design studies to look at what patients want to hear, what families want to hear when they are presented with acute stroke therapy options, what is it the information that the physicians or the clinicians are providing in these interactions that are driving decision making, and maybe amongst ourselves as neurologists, if we can get a consensus about what we feel like this process should look like, all of that information hopefully will inform how we engage patients and their families in acute stroke therapies, and potentially reduce the rate of declination of TPA, hopefully reduce the rate of disparities in acute care. So that's the possibility, that's the sort of opportunity, but it's going to take a lot of work and a lot more conversations, hopefully like this, to get us there.
Well, we will certainly be waiting for that next conversation, Scott, and to echo BJ, I think you've definitely given us and our listeners a lot to think about. These data are important, they're elucidative, and they're provocative, and they should challenge us all to do better, not only in our daily practice, but in the way that we develop our systems of care to do better for all of our patients from all backgrounds. So thanks again for joining us for the podcast. This is just the tip of the iceberg. We really want to encourage our listeners to seek out the full paper. If you take care of stroke patients and you don't take a look at this full paper, you're missing out. Out in Neurology, Race Ethnic Disparities and Rates of Declination of Thrombolysis for Stroke. I want to thank BJ Hicks as well as Scott Mendelson for joining us for the podcast today, and we'll look forward to talking with you all again soon.
Hi, it's Jeff Ratliff with the Neurology Podcast. I'm here with Vikas Kotagal, a neurologist at the University of Michigan. We invited Vikas to join us to discuss a paper he published with his team in neurology clinical practice titled Neighborhood Social Determinants of Health in Patients Seen in Neurology Movement Disorders Clinics. The article was published online on March 16, 2023. And in this study, Vikas and colleagues retrospectively examined the patients coming through their movement disorder center and looked at specific demographic and other census data to evaluate for associations between patients' diseases and social determinants of health. Vikas, welcome. Thanks for joining us.
Thanks for having me, Jeff.
So Vikas, let's just start with the primary findings of the study. And you were looking more specifically at patients coming to your center, examining for associations between their diagnoses and data about the neighborhood in which they live, if I have the findings correct. Can you go ahead and summarize what were the main findings from that analysis and from this project?
We looked at individual patients coming to our movement disorders neurology clinical practice here at the University of Michigan in the calendar year of 2021. And we looked not at patient level factors, but rather at the neighborhood factors associated with the census tracts from which the patients came from, to try to understand factors that describe the neighborhoods that patients are coming to us from amongst our cohort. And it included about 2,400 individual patients. We found that lower socioeconomic status related factors, including a greater proportion of people earning less than $15,000 a year, a greater fraction of people receiving public assistance, and a higher likelihood of people in the neighborhood having less than a high school diploma. These lower socioeconomic status factors were seen more commonly in individual neighborhoods of patients who follow with us for Huntington's disease, for ataxias, or for functional movement disorders, relative to those who follow with us for Parkinson's disease. We also noticed that people with PD or with atypical Parkinsonian conditions like PSP, CBS, or MSA tended to be older than other movement disorders patients and were more likely to be married compared to other movement disorders patients. So those are sort of the two central findings.
Okay, so want to dive a little deeper into some of those diagnoses you examined and some of the social determinants of health that are at play here. The most common movement disorder that we see in our practice is Parkinson's disease, as well as other patients with other Parkinsonian disorders. And you mentioned in the discussion and touched on a little bit just now that patients with PD and the atypical Parkinsonian disorders tend to come from more affluent neighborhoods. Can you teach us a little bit about maybe some of the reasons that you observed that finding?
Yeah, it's a little bit of conjecture, but I think that these are observations that many of us in movement disorders practice have noticed before. One is just that the age of onset of PD, neurodegenerative Parkinsonian conditions, tends to be in adults who are a little bit older than those who are developing nascent tic disorders, for example, or even monogenetic disorders like Huntington's disease or SCA3. So you're looking at a subgroup of individuals who are a little bit older. We found that they were also slightly more likely to be married. And I think that those two demographic factors amongst patients, at least in my guess, associate with slightly more affluent neighborhoods from which those patients come, with the idea being that if you're more likely to be married, you're more likely to come from a dual income household, and that may associate with a greater degree of affluence. Similarly, if the onset of your movement disorder comes later in life, you may have acquired more income and wealth prior to the onset of that disorder. And so your relative affluence may be higher than those who have the onset of their neurologic condition earlier in life.
And so if we switch over to one of those monogenic disorders that you alluded to, was specifically talking about Huntington's disease, you mentioned that patients with HD do tend to come from more disadvantaged neighborhoods by those metrics that you described. And you describe in the discussion of this paper that perhaps even some of the premotor manifestations in HD and Huntington mutation carriers might contribute to difficulties in accessing resources or even doing well in a workplace environment. And so refresh us on a little bit of what you found for patients with Huntington's disease and maybe discuss a little bit about why some of those findings might be coming to light.
Similar to what I'd mentioned previously, I think that many of us who practice in movement disorder specific practices have suspected or noticed these trends in our own patient populations before. And so in many ways, this study is just sort of articulating what I think many of us noticed. And there is a really interesting literature on HD epidemiology as it relates to premotor HD. Premotor HD is often defined by having 36 CAG repeats in your Huntington gene or more, but not yet having the onset of motor symptoms of HD. And that's different than individuals who have an indeterminate repeat length that may vary from 27 to 35. So two slightly different constructs I just want to define there. But there's a literature on premotor HD that suggests that people with premotor HD are more likely to have difficulty finding and sustaining employment and with performance at work, and are also more likely to have sort of non-motor features of HD, including neuropsychiatric features. So it's certainly possible that the presence and persistence of those clinical features may be influencing earning potential and overall affluence amongst HD patients. And I think that for many of us who see HD patients, this is kind of an expected finding.
I think it's important to recognize that in a study like this, looking retrospectively over the patients who came to your center over 2021, determining any sort of causation is very difficult. We're looking at these associations, but thinking about how they fit into a broader context of what we know about the movement disorders that we're describing here. And I think that's coming into play as we talk about patients with functional movement disorders. And again, you described that patients with functional neurologic or functional movement disorders were coming from neighborhoods with lower income or lower average education levels. And so given those caveats about a retrospective study and the difficulties or impossibilities in determining causation, I'm hoping you can describe some of the reaction to these findings. What are the factors that might be going on with respect to social determinants of health for patients we see with FND?
So FND refers to functional neurologic disorders, as you said, and sometimes people use the term FMD, M as in Mary, for functional movement disorders, but I'm going to use them kind of synonymously. And I think an analogous term is PNES, so psychogenic non-epileptic seizures, that characterizes functional disorders seen in epilepsy-specific practices at referral centers such as ours. And there's an interesting literature that exists that shows that PNES, individuals who have PNES whose non-epileptic seizures resolve over time, are more likely to be those who are affluent, who have a college education, who have employment, and those who don't have a resolution of their symptoms are less likely to have current employment status and higher education. So we know that there are, on a big picture level, these broader demographic factors that appear to influence the natural history of functional neurologic conditions. So not only was it interesting to find that in our cohort that FND is associated with relatively lower markers of socioeconomic status, it also raises the question about whether there is some modifiable risk factor that might exist here that could alter the natural history of FNDs amongst patients that we're seeing in our clinic that may not be a risk factor in the sense of a drug treatment target, but is more of a social determinant of health sort of risk factor that could be addressed either through policy or through behavioral interventions or medical education.
That's important as we start to think about modifiable risk factors and sort of pivoting to the portion in this paper where you describe these findings as really begging for a future longitudinal prospective study. And you found a lot of these associations between movement disorders and the neighborhoods that the patients with those disorders are coming from, things like income and education that we've already been talking about. And so what could a future longitudinal study help us learn about some of these associations that you described in this paper?
I want to talk a little bit more about some of the limitations of our approach, because you're absolutely right. It is a retrospective study, and we did not gather information from patients directly. Instead, we used an existing data set called the U.S. National Neighborhood Data Archive, or NANDA, which is linked to census tracts. And census tracts you can think of them kind of like zip codes, but they're smaller. They're anywhere from 1,000 to 12,000 people, and on average around 4,000 people. So they describe discrete areas that are closer to neighborhoods than they are zip codes. But that's not the same thing as actually surveying or asking a patient about social determinants of health relevant to their own life. So one, we have this retrospective design. Two, we're using this large representative NANDA database, but we're not asking people directly. Another important thing is that the data and the inferences that can be drawn from our data are really heavily linked to the context that we're drawing these data from. I mean, we are a university-based movement disorders clinic nested within a suburban town in the Midwest, and inferences drawn from our center may or may not be relevant to movement disorders centers elsewhere throughout the world. I think one relative advantage of our approach is that we were able to capture a large group of people who were given specific diagnoses by movement disorders clinicians, and that in and of itself overcomes a certain hurdle that's often faced by movement disorders epidemiology, which is case ascertainment, particularly for conditions like functional neurologic disorders or even things like Parkinson's disease or tic disorders. So there are upsides of our approach, but there are also downsides. There are many future studies that could come out of this. I think that our work really just barely skims the surface of what role social determinants of health have on patients with movement disorders. I think it would be very interesting to delve into a greater depth in specific conditions like functional disorders, like spinocerebellar ataxias, or even like Parkinson's disease, not just to try to understand associations, but try to understand whether there are associations that are modifiable and that might drive the natural history and outcomes of patients with these conditions, thereby opening up new treatment possibilities that we don't yet have.
Now, knowing what you've learned from doing this study, when you see a patient in the office with Parkinson's disease, or when you're seeing a patient with Huntington's disease or ataxia or functional movement disorders, has the knowledge from this project changed how you're managing or assessing or talking to patients in the office? And could you give us an example of how that has changed your clinical practice?
I do wish I had a very concise way of summing up how conducting the study and seeing these data have changed my clinical practice. I don't think I have something that I can tie up nicely that way. If anything, what seeing this data has done for me, it hasn't so much changed the types of questions I ask patients. I hope it will, but it hasn't yet done that. But I think what it's done is it's made me a little bit more curious about things that I probably ignored previously. Just things like, who's cooking at home? If you're getting in the car, who's putting your walker into the car? If you have a power outage, how do you deal with that? Those aren't really questions that I tend to ask most of my patients, but I'm increasingly curious about the answers to those questions. Often, especially in Parkinson's disease, we do spend a lot of time talking about exercise, talking about the natural history of the condition, talking about diet. But I don't know that we spend a ton of time talking about the myriad of other just normal social determinants of health that matter and that influence people's lives and probably influence the type of symptoms they experience and the severity of the burden of symptoms they experience. So if anything, I think I'm just more curious about those. And since seeing these data, and I have a broader set of family of questions to ask people these days than I did before.
Yeah, I think that makes total sense. And as we are increasingly aware of these elements of social determinants of health that have the potential to have an impact on our patients with various movement disorders, then you're right, that begets questions that we ask about the environment. Is it marital status? Is it having someone at home who can help them, put the walker in the car and things like that? So I think the awareness is hopefully going to lead to sort of questions for us to just better understand the interaction that our patients have with the environment that they live in and how that can affect their ability to access care or optimize their care or just, live as well of a life as they can. Vikas, thank you. I wanted to thank you for joining us. And for our listeners, I've been speaking with Vikas Kotagal from the University of Michigan about his paper that was published in Neurology Clinical Practice titled Neighborhood Social Determinants of Health in Patients Seen in Neurology Movement Disorders Clinics. Vikas, thanks again for joining us.
Thanks so much for having me, Jeff.
Hey, this is Jason Crowell. Thanks for listening to today's Neurology podcast. Today we have Daniel Luca joining us today. Daniel is a clinical fellow at Toronto Western Hospital, and we asked him to join us today to talk about a paper that he co-authored titled Racial and Ethnic Differences in Health-Related Quality of Life for Individuals with Parkinson's Disease Across Centers of Excellence. This was published April the 5th in the Journal of Neurology. Daniel, thanks for joining us today.
Thank you so much for having me, Jason.
So we have covered several topics in the last couple of months regarding equity and race differences and social determinants of health. The one that comes to mind most readily is Jeff Ratliff's interview with Dr. Kotagal back on April 13th, where he discussed social determinants of health in patients with movement disorders. But today, specifically, we're talking about racial and ethnic differences in health-related quality of life for folks with Parkinson's disease in particular. So before we get into the paper more specifically, Daniel, would you mind just summarizing the key findings from this paper that you all found?
We were basically looking at patients that have Parkinson's disease, and we were trying to examine a very large group of diverse patients. And the main conclusion of our paper was basically that after examining this large cohort of individuals with Parkinson's disease, patients that were originally from racial and ethnic minorities or underrepresented minorities in research in movement disorders had a lower health-related quality of life compared to white patients.
So let's go back and start at the beginning. In the background to this paper, you discussed the fact that African-American individuals have less access to movement disorder specialists and often experience a delay in diagnosis with regards to movement disorders. What else should we know in terms of background? Are there any other papers that are important for us to understand with regards to disparities amongst different races in individuals living with Parkinson's?
Yeah, absolutely. It is known that African-American individuals are less likely than white patients to receive a Parkinson's disease diagnosis and also to receive specialist care or care from a movement disorders neurologist. We also have some evidence suggesting that African American patients might be diagnosed at later stages of their disease, and therefore they might accumulate worse outcomes until they are diagnosed. And there is also some studies discussing that perhaps African American patients can experience greater disability and disease severity compared to white patients, as well as cognitive impairment and dementia. I think what is also important to mention is that there are very few studies that examine this population. So in general, we have very little information just simply because we don't include African American or other racial and ethnic minority patients in our Parkinson's disease studies or at a broader level in our movement disorder studies.
Tell us a little bit more about the data you collected. I understand this came from Parkinson's Foundation's Centers of Excellence, and I think you used a questionnaire that's given at those centers. Is that correct?
Just to go back a little bit, at the Parkinson's Disease Centers of Excellence are basically designated medical centers across the world. Most of the centers are located in the US, but we also have centers in Canada, in Europe, and in Israel. For the purposes of this study, just based on the differences in ethnic designation, we only looked at centers in the United States.
So Daniel, tell us, what did you find with respect to differences in quality of life amongst different races and ethnicities?
After looking at 8,500 individuals or so, we basically found that patients that were not white or patients that came from a racial and ethnic minority background, such as African Americans, Hispanic, and Asians, had lower health-related quality of life compared to white patients. And to our knowledge, this is the largest study evaluating health-related quality of life in a diverse population, including African American patients with Parkinson's disease. And we also tried to determine some factors or understand the reasons behind it. So we performed some additional analysis, and we also tried to establish a picture of how these patients look like, what's their phenotype, what medications they are on, what kind of complications they experience. And I think that the information that we gather is quite useful and informative to clinicians when they're seeing patients in their practice, because we can have a sense of how these patients look like according to their racial and ethnic group in general.
So I understand one of the differences you found in your additional analyses was that some of the quality of life difference might be explained by differences in cognitive performance. Could you unpack that for us?
Once we found that health-related quality of life was lower in patients that were non-white, we did perform additional analysis trying to understand the reason behind it. And we realized that one of the key factors in mediating this association was cognitive score, meaning African American patients specifically, once they had lower cognitive scores, that would mediate this association between health-related quality of life and Parkinson's disease. So we hypothesized that the lower quality of life can be partially mediated by the lower cognitive scores in this population, which is actually well known and established by previous studies. There are definitely some limitations to this, including the fact that we didn't use a very long neuropsych testing, as well as some of these tests have been validated in a majority of white participants. So the validity has been questioned by some professionals in terms of the applicability in other racial and ethnic groups. But we still think that this hypothesis is reasonable and probably worth exploring in more details in future studies.
What other differences did you find, say, for example, with respect to the treatment regimen that patients were on?
So what we did find is that African American patients were less likely to be on dopamine agonists compared to white non-Hispanic patients. And what we thought was very interesting is that despite having similar rates of depression, racial and ethnic minorities were less likely to be prescribed antidepressant medications. And that's even after adjusting or correcting for some clinical data. And obviously, we're just looking back and we cannot say for sure what's the reason behind it. It is very possible that perhaps they had contraindications to being on antidepressive medications, but we thought that this was an interesting data that came from our study.
Great, Daniel. So what would you say in regards to clinical applicability of this information that you all published? How might this change clinical practice?
Yeah, I think one of the key aspects is that we do need more data about racial and ethnic minorities. So I think in the first place, in clinic, especially if you're looking at academic centers, it is quite important to keep an eye open for patients that come from a diverse population, make sure that they are eligible for additional research studies. And at a more basic level, if you're a primary care physician or if you are a community neurologist, I think it's important to keep in mind that despite data suggesting that African American patients have a lower rate of Parkinson's disease incidence, we do know that what we see in these studies is disproportionately lower than compared to the incidence in the United States, for example. So it's quite important to keep in mind that these patients can also be affected by motor and non-motor symptoms, especially cognitive difficulties. It would be important perhaps to screen for cognitive difficulties and also perhaps to take into account some other comorbidities that might play a role into cognition. And besides that, as we were discussing, it's quite important to refer patients to specialists, to movement disorders neurologists if needed, and to provide access to a broad level of services, including physical therapy, speech therapy, exercise, as well as levodopa and advanced therapies for Parkinson's disease.
One thought I had as well was the idea that obviously these patients that you collected data from were seen at Parkinson's centers of excellence. So I wonder if maybe the data might be different if we had a broader cohort of patients that were seen at a broader variety of movement disorders clinics.
Yeah, absolutely. That's a great point, Jason. Parkinson's disease centers of excellence are centers with a designated and specialized multidisciplinary team, including neurologists, physical occupational therapists, mental health professionals, and others, which do not necessarily reflect the type of care that is provided across the US. So I would imagine that if we look at outside these centers of excellence, it's possible that perhaps we have a different scenario where individuals that come from underrepresented or marginalized populations would have even lower health-related quality of life. And we can also hypothesize that they would have even lower access to specialized neurologists, as it was previously demonstrated by other studies.
Daniel, before we wrap up here, any other findings that you think are important for neurologists to know about?
Yeah, so when looking at the baseline demographic and clinical data, we also found some interesting characteristics about the disease and some of the services they accessed. We did find that they had similar rates of physical therapy, occupational therapy, as well as speech therapy use. However, when looking at advanced therapies such as deep brain stimulation, African American patients also had a lower rate of neuromodulation compared to white, non-Hispanic individuals.
Daniel, I appreciate the work that you and your colleagues put into this paper. Again, the title of the paper is Racial and Ethnic Differences in Health-Related Quality of Life for Individuals with Parkinson's Disease Across Centers of Excellence. Again, this was published in the journal Neurology on April 5th. Daniel, thanks for joining us today. Really appreciate you taking the time to speak with us.
Thanks so much for having me, Jason.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.